I didn't tell somebody that, and they kept talking and they started saying some things. And I'm
There you
like, this
go.
is live. Okay, welcome everybody to the webinar. We're going to get started in just a moment here. So you're kind of backstage with us as we're setting everything up. So give us a little time. We're going to go over to Facebook and we're going to give a little message over to Facebook. Then I'm going to get this party started and give you all time to get home from work, sit down, grab a bite to eat, take your phone while you're cooking dinner, listen to us during dinner, whatever is going to make you happy. Hello, everybody on Facebook. Welcome to this edition of the Bighearted Warrior Tour. I'm Lisa Salberg, founder and CEO of the HCMA, and we have a really interesting and fun group of people with you tonight. And we are going to talk everything HCM, but if you're watching us on Facebook, you will not be able to ask live questions. You could, however, stop at this moment and join us and log in. I'm going to ask Julie from my team to go on over to the Facebook page and drop the link where you can join us in the Zoom room so you can take part in the question and answer and do whatever you want. If you are watching this event after May 22nd, 2025 at 7:30 p.m. Eastern Time, we're not going to be in the Zoom room because it's live now. And if you're catching it later, you're going to miss it. So I get everybody over there on Zoom. We've got that set, and we're going to go pull up my slides over here, put them in slideshow mode, and I'm going to get this party started first with launching a survey, making Stacy very happy that I have launched the survey. So as you are all getting used to what I'm saying, I know a lot of you might be familiar with my content and you're really joining us for Aurora's content that's going to come through in just a few minutes. You can take the poll while you're waiting. And I am going to do a screen share and get started here. There we go. It is now 7:31 and we are starting on time. This doesn't happen here very often, so congratulations to our team at Aurora Health for being so punctual this evening. I'm going to introduce the concepts for the evening and tell you a little bit about what we're doing here at the HCMA. So tonight you're going to be dazzled with the moderation of Jamil Tajik. So normally I do a lot of moderating. I'm going to sit back tonight and watch the master work. This is going to be fun. All right, I'll be his co-pilot. So then we're going to hear from his entire team, and I'm going to allow him to introduce the entire team at the conclusion of my talk. We're going to be going through a really great agenda tonight. So you're going to hear some updates from me. You're going to hear some updates on imaging as it is the cornerstone of HCM. We're going to talk about medical therapies, septal reduction therapy, a favorite topic here. A not so favorite topic here is the end stage HCM. What do they offer at Aurora? And then we're going to talk about the role of the nursing staff, the nursing coordinators, the nurse practitioners, and then we're going to take your questions. We're going to try our very best to stay on time tonight. We're going to try to keep our talks short and informative and our Q&A sessions rapid and informative as well. So here's some updates from the HCMA, and I hope that all of you enjoyed our content during February, which was Heart Month. Seems like so long ago. We were able to this year get more proclamations, resolutions, and laws actually passed recognizing HCM Awareness Day. And we're super proud now to tell you that we have a federal bill that has been championed, and we're going to be moving for a federal HCM Awareness Day. This gives us an opportunity every year on the last Wednesday of February, Heart Month, to take a moment to really focus on hypertrophic cardiomyopathy. It has been a really wonderful catalyst for doing educational programming in centers and hospitals, at state houses, and here at the HCMA, we even had an open house while doing a live webinar. That was fun. Okay, it was fun, but it was really hectic as well. So we hope that you start getting involved and start thinking of ways now that you can get involved next February and start thinking about how to plan your HCM Awareness Day event with your family, your coworkers, your schools, your churches, wherever. You have the opportunity to also be champions next year in your state resolution. So if you want to get involved in making sure that happens, you can sign up as an HCMA volunteer and we'll be able to walk you through how to do that. So we've also had some success this year already with the Children's Cardiac Safety Act. with passage of a law in Virginia that now requires every well child examination to include a family heart health history screening, including the 14-point screening for student athletes being done on all children. So New Jersey and Virginia are the first two states to do this. And if you would like your state to enact laws like this, again, you can sign up to become a volunteer, and maybe you can be a state champion and take the lead for your state to make this all happen. What does the Children's Cardiac Safety Act include? We want every child in their well child examinations to be asked about family heart history. We want a professional development tool for healthcare providers with an online training system. And in fact, at this point, we are trying to get that program built with funding from industry and donors so that when we go to a state and we want to provide the law and the infrastructure, we're not pushed back because of cost. We want it to be a zero cost bill. And it's going to take approximately, waiting for the final budget numbers, probably $350,000 to $400,000 to build a CME course that would be updated every year to be as current as possible, that each state could utilize free of charge. And we make sure the education is in the hands of the departments of health and they can disseminate it. So we're working to get the funding for that right now and hope to make that a future part of the Children's Cardiac Safety Act. We want to improve student athlete pre-participation screening physicals to include more education to families and to the athletic teams. And we want to provide the ability of healthcare providers to identify children and families at risk for cardiac disorders, both genetic and congenital. So this goes way beyond HCM, but we want that early diagnosis to happen in families, not just in the individual when it's necessary. We have a couple of pieces of legislation moving through Pennsylvania. Virginia passed their bill. Rhode Island, and we have some draft legislation under, well, no, actually, we have a bill number there now. Sorry, this is a little out of date. And then we also have work going on in Minnesota, Pennsylvania, and Texas. So if you live in any of those states and you're interested in getting involved, or if you don't see your state on here, like Wisconsin, and we can do something to help move that forward, please get in touch with us. You don't need to be a patient. You can be a professional, paraprofessional, anybody interested in the cause, we're happy to have as a state champion. The All Hearts Collaborative is moving ahead beautifully here in New Jersey, and this is a program where we are going into one particular community as a pilot project to raise awareness about the importance of knowing one's heart health history, specifically in communities of color. We're going into Newark, New Jersey, and we have built an amazing program with community partners, faith leaders, the governmental agencies, the hospital systems, the community health workers, and now we're going to start going into churches delivering messages about why knowing family heart health history is important and what to do if you have any indication of heart risks and how to determine what specialists you might need. And then we're aligning these individuals with healthcare workers directly in the community that we've already provided training to about the diseases that we're looking for. Specifically in this case, we're starting with HCM, obviously, amyloidosis, because it's one of the most common mimickers in the Black community, and uncontrolled hypertension. So if we can start providing educational tools to families to get these conditions managed, we can improve outcomes and save lives. This young man on the slide is Derek Armstead, and he was lost at far too young an age after he had collapsed, after he'd gone to the emergency room, after they released him from the emergency room, without ever asking about family heart health history, without ever doing any cardiac evaluations after syncope. If they'd asked the questions, they would have found out that his mother died before the age of 30 while waiting for a heart. Unfortunately, 5 days after that hospitalization, Derek died. He had a cardiac arrest while carrying his son up a flight of stairs. And I couldn't help but wonder if Derek was a different color, if he was a different age, if he was a different ethnicity, would his treatment have been different? Would he have been asked about his family heart health history? Would he have been offered care? We'll never know the answer to that, but we can make sure another Derek doesn't happen. And that's where the All Hearts Collaborative was born. And we hope to prove our pilot and be able to bring this program out into other communities by 2026, 2027. If you're interested in learning more about All Hearts or you want to bring it into your community, give us a call and we'll set up something to talk. The Lori Fund is growing and it's doing so well. If you're interested in applying, if you're interested in donating, there's opportunities on the screen here. What is the Lori Fund? If you or a loved one has hypertrophic cardiomyopathy and you need funds to get to an HCMA recognized center of excellence or a transplant program or hospice care, if you are in any of those circumstances and you need funding, we can provide you with $599.99 if you qualify. You submit your receipts. Obviously, for hospice, we just give a grant of one time $599. If you are looking to travel to a center, you need a hotel room, you need a train ticket, you need a plane ticket, we'll give you $600 towards that. Actually, $599.99. It's a tax thing. So if you need the funds, please apply for them. People have been generously donating to the Lori Fund since we started it 2.5 years ago. We've already given out about 15 or 20 grants, and they have really helped to improve the lives of those who've used them. So if you need funds to get somewhere, please apply. If you feel like donating, please do. Your money is going to go pass right through us into somebody else's hands. We charge a small processing fee when we process a grant, so it goes into general funds, but pretty much every dime here is going back to the patients and making sure that they can get to the care that they need. Obviously named in memory of my sister, Stacy's mom, Lori. Tales from the Heart, the podcast. I did an edition today with Alex DeFaria, and Alex got me off target here. He got me. We started talking about the medical management. May is the theme. And he asked me about my stroke and whether I thought antibiotics were necessary before dental work. And I'm like, yes, I had dental work. I got endocarditis. I threw a clot. I had a stroke. I almost died right after my wedding. I do believe in that. So if you want to hear the whole conversation, you can go over to Tales from the Heart, our podcast, and listen to it. It was actually an interesting conversation. We went down a couple of rabbit holes. We discussed Odysseys, the clinical trial Odyssey, and a few others. So I would encourage you to go look at that. If you like listening to content and you want to learn more about your heart and more about the HCM community, stop by anytime. I get wonderful guests. If you haven't been to a discussion group yet, there's a newly diagnosed group starting at 9:30 tonight. So if you get done here and you really want more content, Linda will be running the newly diagnosed room tonight. We have transplant groups, ICD groups, medical management, emotional support, myectomy, and so much more. These are all run by passionate volunteers who are committed to you, the community, and I can't thank them enough for all of the work that they've given. The numbers are a little outdated there. We got to get some updated numbers, but that's what we did in 2024. The program continues to grow. There will be some new programs coming up in the fall, so stay tuned. We're adding to our ambassador program now. If you're one of the, about 40 people who've recently signed up to become an ambassador, thank you. We're going to be onboarding more soon. This is a group that there's never enough. If you want to jump in now that we have built this program, you want to be an ambassador. If you're a patient, if you're a caregiver, if you're in clinical care of people with HCM, you can be an HCMA ambassador. What does it mean? Use your social media platform to raise awareness, share information about HCM, and maybe if you want to, go out and do live events as well. But mostly it's a social media ambassadorship. And if you want to sign up, this is how you do it. Just click that QR code, or Julie down there at the bottom of my screen here. Julie can help you get set up as a volunteer as well. Bighearted Warrior Tour is on the road. We're heading to Seattle in July, on July 26th. So if you're on the Pacific Coast and you want to come see us, well, Pacific Northwest, please come by and see us. Registration is now open, so you can start signing up. We will then be in Baltimore on September 13th, Pittsburgh November 15th, and of course, we will be in Morristown, New Jersey on October 18th for our annual meeting, which will be during the day. We're also going to be having, Dr. Tajik's going to like this one, we're going to be having a CME course focused on imaging, partnered with ASE. So that's going to be up front. So thank you to Morristown Medical Center for helping us do that piece. And then when we're done doing all the work during the day, we're going to run upstairs and we're going to get dressed and we're going to come down for a party. and we're going to have a gala. It's going to be Unmask the Great Masquerader 2 or 3, I think this is. And it's a fun event. We're going to raise some money, and we're going to be honoring Dr. Stephen Winters, one of our first board members, member of the faculty at Morristown as the director of electrophysiology and dear friend for 40 years. So we're honoring him. And the next day, we're going to have a 5K. So we're going to really see how exhausted somebody with HCM can get by making them sit all day, party all night, and run the next day. There will be EMS standing by with defibrillators. Okay, that was kind of a joke, but not really. There will be. So if you can be with us for this weekend, we encourage you to sign up. We just finished polishing up the agenda today, and we are going to go deep. We are going to have meaningful conversations. We're going to provide a lot of education and opportunities for you to get involved in advocacy. I want to say thank you to everybody on our team, specifically tonight to Stacy and Julie, who are here with us. The rest of our team is here on the screen. This is not me sitting here behind a desk doing everything. It is a comprehensive group of individuals, both staff, contractors, and volunteers, making all of this happen every day. And of course, nothing would happen if we didn't have the funding to do the work. So thank you to our sponsors at Cytokinetics, Viz.ai, Rocket Pharmaceutical, Edgewise Therapeutics, Bristol Myers Squibb, Tenaya Therapeutics, Imbria, Avidity, I always say that one wrong. And there's a couple new ones coming on board very soon. So to the pharma industry who is finally seeing hypertrophic cardiomyopathy, thank you. We need you to keep fighting for us. We know it's difficult times. So thank you for your support. And I'm going to turn this over in just a minute, but I end almost every one of these presentations with a bit of gratitude to somebody very special to me, and that is my organ donor, Brandy, and her family, because I am only here tonight with you because of clinical trials, medical research, and a family who said yes to donation. So never forget to let your family know how you feel about being an organ donor. Somebody might need that someday, and you'd want your wishes granted. And I know Brandy's family did that for her. So wrap that piece up. Now let's get back to work here. Dr. Tajik,
Here I am.
your team is here. Why don't you walk everybody through your team and the agenda, and then I'm going to hand off to you for the rest of the evening.
Well, this is how we're going to start. As soon as I get on that screen. Thank you. Your update was fantastic, very inspiring, and a lot of work you're doing and your team is doing. So that's very exciting, and we'll hope to join you along the way, somewhere along the way. So, as part of a little introduction to HCM from our perspective and the team introduction, I thought I'm going to start with a little bit of my personal odyssey. Started with HCM in 1970 and it's going to 2025, 55 years and beyond. So here's my personal odyssey that I will share with you. And I'm going to give you a 3,000 feet eagle eye view to this odyssey. So that's basically what's going to be. So before we start with the 1970 era and beyond, in the mid 1960s, late 1960s, Dr. Barnwell team, including the surgeon Dr. Morrow from NIH and their colleagues, described this condition referred to as muscular subaortic stenosis, or what they call IHSS, idiopathic hypertrophic subaortic stenosis. And they described the hemodynamics of it, described the dynamic nature of obstruction, and Dr. Morrow came up with a surgical technique of septal myectomy to relieve the severe obstruction present in these symptomatic patients. So that was all in 60s. 70s, the name of this condition was changed from IHSS to hypertrophic cardiomyopathy, and that was accepted across the globe. Hypertrophic cardiomyopathy. And then came echocardiography, M mode at that time in the early 70s and late 70s to the echo, which are the backbone of assessment, hemodynamic assessment now, and the whole basis of assessment of these patients, and we'll hear a lot more about it. And then beta blockers became established for treatment, and Morrow's myectomy was modified and extended, and further sophistication was done. Next, 80s is when calcium channel blockers and Norpace was introduced in the armamentarium to treat these patients, and we're only referring to the obstructive variety of hypertrophic cardiomyopathy. And now let's go on to the next decade, 90s. Fantastic developments occurred, and most exciting was the discovery of the gene, first gene to account for hypertrophic cardiomyopathy, beta myosin heavy chain, and since then, great developments have occurred in this field. We don't have time to go over that. This is an eagle eye view of the road that we are traveling on in this entity. Pacemaker therapy was introduced for relief of reducing the LV outflow tract obstruction in selected cases. And then alcohol septal ablation came about in the same early 90s, but gained momentum in the 2000s. And ICD for primary prevention of sudden cardiac death that accompanied this condition in select people was also introduced. So a lot of important developments occurred in the 90s. And my colleague, Dr. Fuad John, of course, is scheduled to present an update on the septal reduction therapies, myectomy and alcohol septal ablation. Now to the 2000s. Multimodality imaging took its total force, and that's where Dr. Galaska will come in. Dr. Galaska is a superb clinician, expert of hypertrophic cardiomyopathy, big time imager of multimodalities, and a fantastic human being, individual, co director of the hypertrophic cardiomyopathy clinic at Aurora, and will provide that information. Next is 2010. Another fantastic milestone started developing in the 2010s, later in that decade, and then came to fruition in 2022 in the form of a medication, mavacamten, Camzoos, which has been a tremendous game changer. And my colleague, Dr. Peters, will describe these myosin inhibitors, including aficamten, where we stand, and give us an update on that. And finally, our colleague, Dr. Gafoor, advanced heart failure therapies expert, also very much involved in HCM clinic and with amyloid heart disease, will address this challenging subset of patients that don't have obstruction but have tremendous diastolic heart dysfunction, heart failure, and require advanced treatments. And he will address that. And finally, and very importantly, these two individuals are critical for the success of our HCM clinic and to continue this journey in a very efficient manner. Amanda, nurse coordinator, and Heather Sanders as our nurse practitioner. So with that little background about HCM journey, I feel this has been a fantastic journey and more fantastic developments in the field are yet to come. Stay tuned, and I'd like to introduce and invite my colleague, Dr. Galaska, to tell us about the cornerstone that imaging is for HCM. Patricia?
Thank you, Dr. Tajik. Thank you, Lisa. Thank you for this privilege of being part of this webinar today with you and our patients. As many of you know, imaging is very dear to my heart as I'm a multimodality imager. And I love going over images with my patients in clinic because I truly believe seeing is believing. If you can see something, you can truly know what you're looking at and understand your disease in greater detail. So with that, let's start. We'll talk today about imaging and why is it the cornerstone, or why is it so important specifically in hypertrophic cardiomyopathy. So why imaging matters? Well, everything starts with imaging, and we know that diagnosis is the most important thing, and proper diagnosis often leads to correct therapies and correct disease evaluation. So echo and MRI both allow us to help with diagnoses of hypertrophic cardiomyopathy, but they also add something more to each other. They all have its additional values, and this is what we're going to talk about over the next few minutes. Echo and MRI diagnose. Cardiac MRI helps us with sudden cardiac death prediction or stratification. Moreover, we have more tools in our toolbox. Other tools that we frequently use is, for example, coronary CTA, which helps us for evaluation prior to medical or surgical therapies, as well for evaluation of coronary artery disease. We know that hypertrophic cardiomyopathy also have coronary disease as we get older. We need to know if it's present and in what degree it is present. Moreover, in order to further evaluate symptoms, we know that, for example, patients with hypertrophic cardiomyopathy can have microvascular dysfunction. We know we frequently use imaging in combination with stress testing, such as stress echo, or cardiopulmonary stress testing, or nuclear imaging, such as PET, SPECT, or other forms of imaging. So again, why imaging is so important? It leads to diagnoses, and diagnosis is extremely important because it changes our management and it leads us to proper care of the patient. So how do we diagnose hypertrophic cardiomyopathy in our patients? Well, it all starts with this increased wall thickness that we can see either on echo, as we can see here, on cardiac MRI, or on cardiac CT. And frequently, echo is the cornerstone or the most fundamental imaging modality that we use initially. And this is done because of symptoms that patients may have, whether it's shortness of breath, chest pains, palpitations. But hypertrophic cardiomyopathy is diagnosed when the wall thickness is increased. And that wall thickness can be increased anywhere within the left ventricle, which is the main pumping chamber of the heart. And as you can see here, this particular patient has an increased wall thickness within the basal septum, or the wall which divides the right and the left ventricle. And it's diagnosed when it's more than 1.5 or more than 1.3 centimeters if there's a family history or when there's a genetic component in hypertrophic cardiomyopathy. But of course, we need to exclude other etiologies or phenocopies when this wall thickness is increased, because we know that there could be other metabolic or syndromic diseases which can result in this increased wall thickness. And proper diagnosis or proper evaluation of wall thickness matters, and this has been shown again and again. When this wall thickness is higher, especially when it's over 30 millimeters, there's definitely much higher increase in sudden cardiac death or arrhythmias. And this is a continuum. So the thicker the wall, the higher the chance or the higher the risk of sudden cardiac death, as you can see here within this heart. So echocardiography, as I've mentioned, is truly the cornerstone as initial fundamental imaging modality in hypertrophic cardiomyopathy. So it not only allows us to see the wall thickness, as you can see here, this patient's wall thickness is about 3.5 centimeters, but it also allows us to see additional features in hypertrophic cardiomyopathy, which can be present, such as abnormal papillary muscles, chordal insertions, mitral valve apparatus abnormalities. It also allows us to see what is the diastolic dysfunction of the patient, or what is the stiffness of the heart and at what degree there is this stiffness present. The systolic function, which we frequently talk about during our visits, we talk about the function of the heart, and we know that patients with hypertrophic cardiomyopathy frequently may have normal systolic function, yet when we do this longitudinal strain, global longitudinal strain of the left ventricle, it can be abnormal. And this we can see with echocardiography. Moreover, Echocardiography allows us to see the hemodynamics within the heart. So whether obstruction is present, and again, this matters when it comes to therapy and further evaluation of the patient. Also, we see the degree of mitral regurgitation, which can result in symptoms and other things. And echocardiography, there's a lot of indications for echocardiography within our HCM guidelines, as you can see here, from the initial evaluation to repeating it every 1 to 2 years for this evaluation of wall thickness, dynamic LVOT obstruction, mitral regurgitation, and function, to following up it during therapies like such as mavacamten, to prior to septal ablation therapies, myectomies, or during procedures. And hemodynamics truly really matter, and bringing out that obstruction in hypertrophic cardiomyopathy is extremely important for the patient, as again, it can determine what therapies can be used. And frequently when our patients come to our clinic, we obtain a specialized echo and we try to bring that obstruction out. We initially do Valsalva maneuver. We have patients stand up, check those gradients during those maneuvers. And sometimes we'll ask our patients to go back and have a larger meal and come back and actually evaluate them after a larger meal, as we know that these gradients on this obstruction can vary on echo depending what is the heart rate, blood pressure, volume status, how much food a patient ate, or whether there was any alcohol consumption prior to it. And the proper Valsalva is extremely important in order to bring out those gradients or that obstruction. And this is highly dependent on the sonographer education, who can educate the patient how to perform the proper Valsalva maneuver during echocardiography. And you see here, this is an example of a patient who had the gradients checked at rest and postprandially after a larger meal, and these gradients definitely come up afterwards. And Dr. Tajik has shown this before, where we know that patients who we can bring out that obstruction, and timing of the LVOT gradient is extremely crucial as the hemodynamics change. And we frequently will recommend smaller meals and increase intake of non-caffeinated fluids and fluids for our patients in order to decrease that obstruction. So thank you, Lisa, for this image here of this beautiful heart. This is from American Society of Echocardiography from last year. And thank you, Dr. Tajik, for taking this beautiful picture. And we can see here that echo and CMR, as you can see, this is a picture of a hypertrophic heart, and echocardiography and cardiac MRI can both show us the location of this, where the hypertrophy or the increased wall thickness occurs within the heart, can show us how these papillary muscles, which insert into the chordae and then mitral valve, how thick they are or where they are located, whether there are any abnormal attachments or whether there's elongated mitral leaflets. And we can see it all with echo and cardiac MRI, and all of these abnormalities, as you can see here, truly can lead to LVOT obstruction and as well as mitral regurgitation. So we try to elucidate that with both echo and cardiac MRI. So what does cardiac MRI add on top of echocardiography? Well, cardiac MRI, I always think of it as non-invasive tissue biopsy. We're able to look inside of the heart and we're able to truly evaluate the heart muscle, from the degree of fibrosis or scarring that the patient have, to even able to see if there's interstitial fibrosis or the way where the fibroses that or the scarring which we can't really see. And this is what we see, this very thick heart muscle here on the left. We can measure it in great detail with cardiac MRI, especially when echo is inconclusive or we're not able to see something well on echo. And then we can see the scar on MRI that we calculate and quantify later on. And cardiac MRI also has many indications in our guidelines. And initially, we do it for sudden cardiac death stratification or for further morphological evaluation. And then we tend to repeat it every 3 to 5 years for further sudden cardiac death stratification. But what cardiac MRI can do, it can unlock other phenocopies or mimickers of this increased wall thickness. You can see here, this is a patient with cardiac amyloidosis, Fabry's disease, or for example, when we have a patient where we can differentiate between athlete's heart, whether it's a normal heart or whether it's abnormally pathologically thickened heart, cardiac MRI can certainly help with this because it's a non-invasive tissue biopsy of the heart. Most importantly, again, cardiac MRI helps us risk stratify for sudden cardiac death. You see here that we frequently look how much does the delayed ganglion enhancement exist within the heart muscle out of the total mass. And here, this patient has truly extensive delayed gadolinium enhancement, whether there's left ventricular aneurysm, whether there's scarring within that area. And we know that this delayed gadolinium enhancement correlates to pathology really, really well and scarring within the heart. And it's also included in our guidelines for further sudden cardiac death stratification. And how much scar really matters? Well, there's several papers out there. Most recently, there was a meta-analysis that was released that anything over 10% has the highest accuracy for arrhythmia and sudden cardiac death. Previously, what we've included in our guidelines, it's more than 15% of the total myocardial mass, and we call this extensive myocardial myocardial delayed gadolinium enhancement, and this is what we use, the 15% for sudden cardiac death stratification when we think about ICD placement. What about cardiac CTA? Well, cardiac CTA adds more. It can truly look at anatomy in great detail, has great spatial resolution, but most importantly, we can look non-invasively at your coronary arteries, and we can see how much scar there is and whether there's calcified, non-calcified scar, whether there's a degree of stenosis. We can also appreciate myocardial bridging, where the coronary artery runs within the heart muscle, and about 40% of patients with hypertrophic cardiomyopathy have that, and we can use it for pre-procedural planning. And it also has a role in our guidelines. And this is a patient who has had chest pain, and we know that patients with hypertrophic cardiomyopathy frequently have chest pains, who underwent coronary CTA for evaluation of coronary disease, and we can see that these coronary arteries look normal. Versus this patient has large amount of scar within, large amount of plaque within the coronary arteries and has severe stenosis within one or two arteries. And what about cardiac imaging and stress testing? Well, we frequently employ either a stress echo or a cardiometabolic stress testing with a stress echo together for our patients to further assess whether there's a provocable gradient after the exercise, whether we can elicit symptoms. And cardiopulmonary stress testing specifically helps us to evaluate peak VO2, which we know is predictive of ventricular arrhythmias, progression to heart failure, higher all-cause mortality. And finally, nuclear imaging is important, but not as important as echo, obviously, and as cardiac MRI, but it can help us further exclude phenocopies. For example, with PYP nuclear imaging, we can exclude ATTR amyloidosis. And we don't often use SPECT or PET, but we can look for microvascular obstruction with PET, as over 50% of hypertrophic cardiomyopathy patients will have perfusion defects without obstructive CAD on nuclear imaging. So each modality truly adds something to other. They're all complementary, but they help us further evaluate and diagnose our patients with hypertrophic cardiomyopathy. So some take-home points for all of you. Multimodality imaging is truly important and essential in hypertrophic cardiomyopathy. It provides important insights into anatomical, functional, and prognostic aspects of hypertrophic cardiomyopathy, and aids in sudden cardiac death stratification and evaluation for therapeutic interventions. And with that, I thank you for being here.
Thank you so much. I am going to take the mic for just a quick second, Dr. Tajik, just to have everybody do the poll real quick I'm going to launch the poll in just a second. And that way we know who's actually listening, and to remind everybody to use the question and answer box at the bottom. And at the conclusion of tonight's presentations, we will be addressing your questions. We cannot do consult via webinar, so make your questions generalized so we can answer them specifically. I'm going to end the poll now. We've got 68% of you showing up. So let me show everybody what we're dealing with here. Sharing the results. We've got patients from, or I should say, we should have participants from the Northeast, the West, the Southeast, Midwest, and Asia tonight. We like to see where we hit in the world. Only Asia tonight. So you never know. Of the participants here tonight, we have 60% are patients, 20% are family members, 14% are industry related. Hello, Nikki and Juliet. I see you. We have some medical care providers and somebody who's just curious. Just curious, send me a note because I'd love to know how you found out about this if you're just curious. Next question is, have you or a family member had any of the following? Are you on medication? 66%. Do you have an ICD? 23%. I've experienced atrial fibrillation. 34%. Lost a family member to HCM, 17%. Have had genetic testing, 54%. Diagnosed in the last 2 years, 11%. Have had septal reduction therapy or alcohol septal ablation or myectomy, 20%. One person, 3%, is considering septal reduction surgery tonight. No pressure to those producing their talks on septal reduction therapy. 17% have participated in a clinical trial, 14% are interested in a clinical trial, and none of the above applied to some of the people. Are you or a family member considering a new medication or device at this time? 17% yes, 57% said no, and then we got a no answer. Are you or a family member currently being seen in a recognized center of excellence, HCMA recognized center of excellence? 49% yes, 26% no, 6% unsure. Lastly, I think this is our last one. If applicable, are you seeing the center that's being featured tonight? And 20% or a few of your patients are here, the rest are shopping. So no pressure, guys, no pressure. So that just gives us a little understanding of who's trying to gather some more information. Where is everybody in their journey? So now you have a little bit better idea of who you're speaking to. I should have done that before I handed it to you,
Yeah,
Dr.
no,
Tajik. So now I hand it back to you.
Lisa, that was very helpful to hear all the numbers. How many had genetic testing done? You said something, I missed it.
50% of the people tonight, so out of those who did the poll, 19 out of 34, or 54%, have had genetic testing. I know how strongly you feel about genetic
Oh,
testing.
yes. Yes. Okay, more need to be done. More need to be done.
Absolutely. Back to the agenda.
Okay, so again, thanks, Patricia. That was great presentation on multimodality imaging, a nice update. And now we move on to, after we made the diagnosis, did all the assessment, what medical treatment, what's the latest in medical treatments, and Matt Peters, who's not only a multimodality imager, but also an active member of the HCM clinic, is going to present an update there. Matt, are you there?
All right. Thank you, Dr. Tajik.
Yes.
I'll pull up my screen here. All right. Well, thank you, Dr. Tajik, for the intro, and thank you, Lisa, as well. Excited to be talking to everyone tonight. And I think this is a really important topic. We'll just be giving a broad overview of some of the big updates, just to get everyone up to speed. But once we've made the diagnosis and gotten a lot of great information from the imaging like we just talked about, then the next question is, what are we going to do about it? So obstructive HCM is what I'll talk about first. So what is obstructive HCM specifically? We already spoke a little bit about some of the anatomy of hypertrophic cardiomyopathy. But when we have a thickened heart muscle, in some patients, the blood flow leaving the heart can be blocked by that thickened heart muscle and the mitral valve. That can lead to symptoms like shortness of breath, chest pain, fatigue, dizziness in some individuals. And this obstruction, as we had just spoken about, can be worsened by different factors like when exerting yourself or when dehydrated. So normally on our diagram here, we have with the yellow arrow, that's the outflow of blood from the heart to the aorta. Usually it has a nice wide open path. But as we can see here with the smaller arrow, once we have in some individuals, if we have thickened heart muscle, then we can block that blood flow leaving. And so that's one of the main areas that we want to address with medical therapies. So why would we need new medical therapies? As Dr. Tajik mentioned at the beginning, we've had many decades of treatments for hypertrophic cardiomyopathy with things like beta blockers, calcium channel blockers, disopyramide or Norpace. These medications are very helpful for a large number of people. So there are many patients who are on these medications to treat their hypertrophic cardiomyopathy and are doing great on those medications. But not for all patients. So there are those who these medications aren't effective for or don't fully relieve symptoms. So those with residual symptoms are often looking for another option. And sometimes people have side effects that can limit the doses of medications and prevent us from reaching those therapeutic doses of medication. So things like low heart rates or intolerance to medication. And so in the past, procedures are what are thought of when medications aren't enough and if patients are still having significant symptoms. But that has created a need for new medical therapies, which has really sparked a lot of research in the last decade that has brought us real clinical advancements. So myosin inhibitors are the main drug that we look to as our second option after we've tried some of these traditional medications that we've had more experience with. These medications work directly on the heart muscle, so they're designed to be specific for hypertrophic cardiomyopathy. We don't use them in any other medical conditions. They reduce excessive contraction, so they stop the heart from beating too hard or squeezing too hard, and that relieves some of that obstruction in the heart. They work directly on the actin and myosin inside the heart, so on a biochemical level, they block these two molecules from interacting, and that leads to relaxation of the heart. And so they don't slow the heart rate like some of our other medications do. And the goal is to improve heart filling, reduce obstruction, and by doing that, relieve symptoms for patients. So mavacamten is currently our only FDA-approved medication in this class. This is approved in 2022, so still a relatively new medication. And this is for patients who do have that finding on their imaging on echocardiogram of obstructive hypertrophic cardiomyopathy, and those who are having symptoms related to it. So that's why the imaging and diagnosis is very important to make sure we're finding the right cause for chest pain or shortness of breath. The Explorer HCM trial from 2020 was the trial that really introduced this drug and showed the efficacy. It showed that patients had improved exercise capacity, improved symptoms, and improved gradients who took this drug. It does require monitoring for safe use. So there's regular echocardiograms and clinic visits that are required to make sure that the drug is at the right dose that's safe for each patient. But in general, it does have a very high safety profile, and patients in general tolerate it very well. So this is used throughout the country in clinics now. So this has become a very popular option that can really help patients out quite a bit. And it's so effective that we've seen in this trial called the Valor HCM trial from 2023 that if we looked at a group of patients who might have qualified for a surgery to reduce the size of their heart muscle, 80% of those patients who took mavacamten no longer qualified based on the criteria for surgery, meaning that they had their symptoms reduced to a point where surgery wouldn't be an option anymore. So this has really helped this trial to show that this drug is a powerful way to delay or avoid invasive procedures for the right patient. And we can see here, this was the original mavacamten group. All of them at the beginning of the trial qualified for a surgery. And then already at 16 weeks, it was down to 20% of patients who qualified from 16 weeks of taking the medication. So we looking to the future. We do have another drug that's on the horizon. So aficamten is a next drug that's in the same class as mavacamten, or Camzyos is the trade name. So this new drug aficamten has been undergoing trials in the past year. It has not yet reached FDA approval, but we may see that within the next year. So this is not one that can be prescribed currently, but I think it will allow an extra option potentially for patients to choose between. Some of the things that people are hoping is that it may allow for some increased flexibility in dosing, and it should have fewer drug interactions with other medications. The Sequoia trial was the trial, hence the trees that we have on the picture here, that showed improvement in exercise capacity similar to what we saw for mavacamten. Looking to patients who with non-obstructive hypertrophic cardiomyopathy, so meaning those who don't have an obstruction, we know that some of those patients still have symptoms related to stiffening of the heart. So the Acacia HCM trial is another tree-named trial of aficamten. And this is a phase 3 trial, meaning it's being tested right now in patients. And this is looking at this drug aficamten and whether it's beneficial in patients who don't have an obstruction. So this trial is mainly trying to see if we can improve exercise capacity in those patients and symptoms. St. Luke's is participating in this trial, but we recently closed our enrollment, so we're hoping to see the results from this soon. There was recently a trial that Lisa had mentioned as well, the Odyssey trial that did not also examined mavacamten for this purpose, and it looks like right now we weren't seeing any results that were showing a benefit from the preliminary data. So we'll look for the full trial to be able to examine what exactly happened with that, and then hopefully with this trial we can get some clarity if these myosin inhibitors are helpful for this group of patients. The Sonata HCM trial is another trial ongoing right now. This is looking at sotagliflozin, which is a SGLT1 and 2 inhibitor. So it's similar to drugs that are already used for heart failure currently, but it's a slightly different medication. This trial is trying to look at if this drug can improve symptoms for all patients with symptomatic HCM, so those with an obstruction and those without an obstruction. So that includes more types of HCM, so patients with non-obstructive HCM related to thickening of different parts of the heart muscle, and including the apical HCM. So this is currently open for enrollment, and St. Luke's is participating as well in this trial, so we're excited to see where that goes. So the future of medical treatment is very exciting. So I think with a lot of optimism with how medications can help patients based on what we've seen already with mavacamten. And really more options just means more personalized treatments for patients. So I think having more choices is always better. So we'll look forward to these new developments and new trials. And we, as physicians and clinicians here, are here to help all our patients stay up to date on the newest cutting edge therapies. So, we're very excited about our role in learning about all these new drugs as they're made available and making sure the right patients are receiving that information and able to choose for them what's the best therapy. All right, and thank you.
Thank you, Matt. That's very nice, beautifully done, and very appreciative of showing where we are heading with the exciting new drugs that are coming out for this particular disease with obstruction and now with non-obstructive disease as well. So we move on next to my colleague Fuad Jan. Fuad Jan is also an HCM expert, but in addition to that, he is an interventional cardiologist. And I don't see him there right now. Anyone else sees him?
I'm here.
He's here.
He's here. Okay, good. So then for John, we'll talk about septal reduction therapies, surgery, and alcohol septal ablation, and he may have something else in his pocket as well to share. Fuad?
Well, I'm going to try and share the presentation.
Okay.
I'm working on it, I guess.
While you're working on it, I'll take the moment to say you have a question and answer queue underneath. If you need to ask any questions, please do. Just thought I would impart on the entire team that Janet is here, and she said, I see the center here tonight, and they are awesome. So just what you want to know, you got a fan in the audience, yeah.
So I will also take this moment to thank the people in the audience, patients with HCM who volunteer to come into these trials, help
Yes.
advance the science, participate in it, and as Matt Peters mentioned that we are enrolling patients right now actively enrolling in Sonata trial at Aurora St. Luke's Medical Center HCM Clinic. And here we go.
You guys see my screen or no?
You're not in present mode. We're seeing your other screen. So swap screens.
Let me see, where is the present mode?
If you go to display settings, I think you can just swap yourself.
We'll go to, well, I clicked on the share
If you look on your screen where it says display settings,
on my.
I think you have two screens, right?
No, I have just one screen.
Oh, really?
Oh yeah, I have two screens, you're right.
I'm like, I've never seen this on a single screen. So if you click on the display setting and just swap the screens, you'll be in display mode.
Maybe I will just disconnect the other
No,
screen.
no, no, just click the display screen and it'll one click and you'll be done.
Just click the display screen. Okay.
If you hit display screen setting or display settings, second option on the top, your cursor's on it now.
Wait, wait. Okay.
I lied, that's mine.
While Fuad is
What am I supposed
ready, Asad, I hope you are all connected and ready to go as soon as Fuad is done.
to I had to click on what? I did say screen sharing, but
Not screen sharing, but if you go to display settings on the top of the bar, it says show taskbar and then display settings and then end slideshow at the top of your screen.
display
Right there,
settings.
click there and swap.
Yeah. How about now?
I'm brilliant. There you go.
Thank you very much for your help.
Of course, I've done this once or twice or 1,000 times since the start of COVID.
All right.
It's all yours.
So I'm going to briefly talk about septal reduction therapies in hypertrophic cardiomyopathy. And we'll start by talking about the guidelines. What do the guidelines say? The American Heart Association guidelines, the American College of Cardiology, they recommend septal reduction therapy for the following subset of patients with obstructive hypertrophic cardiomyopathy. So it's specific to obstructive hypertrophic cardiomyopathy. So patients who are severely symptomatic, which is typically New York Heart Association class 3 or 4, so less than ordinary activity or even at rest, despite guideline-directed medical therapy that Matt was talking about earlier. These patients will also have left ventricular outflow tract obstruction and gradients more than 50 millimeters of mercury. So obviously they're symptomatic and the gradients are very high. They have an appropriate septal anatomy, which can be described particularly in terms of alcohol septal ablation, and obviously for surgery as well. And they also do recommend that it should be performed only at experienced HCM centers with demonstrated procedural excellence. So that's an important point. The guidelines do recommend in septal reduction therapy in symptomatic patients with LVOT gradients and septal anatomy that's appropriate, but they do emphasize the fact that they should be performed at experienced HCM centers and not at places where there's not much experience with the condition. The rationale for the septal reduction therapy is to relieve the mechanical obstruction that's subaortic in this case due to by enlarging the cross-sectional area of the outflow tract. So most of you will have heard terms like left ventricular outflow tract obstruction and systolic anterior motion of the mitral leaflet, which is involved in generating the obstruction. And by relieving and by enlarging the cross-sectional area, you're able to increase the area and also abolish the systolic anterior motion. In the vast majority of cases, it's the anterior leaflet that makes the contact with the septum, the ventricular septum, which Dr. Galazka talked about earlier as far as thickness is concerned. And this mechanical outflow obstruction occurs when the jet is ejected by the heart, and the pushing force allows a drag on the mitral valve and causes the contact with the septum. and causes the obstruction. So septal reduction therapy is rationale for this, again, we talked about, is to relieve the obstruction, but there is a robust evidence for its help that it affords in patients. And when performed in experienced centers, it provides symptomatic improvement, relieves the obstruction, improves the quality of life, and in general has low procedural risk. And data, particularly from the SHARE registry, indicates that the majority of patients who receive the septal reduction therapy have sustained gradient reduction and therefore symptomatic relief with a 10-year event-free survival that exceeds about 80% or more. Older age at intervention and female gender are associated with a higher risk of heart failure progression after septal reduction therapy. Again, the timing is important, waiting for too long, more scar formation, more diastolic dysfunction, increased thickness in the heart may all be related to that. Now, surgical myectomy is one form of septal reduction therapy. It's the preferred one according to the guidelines and the evidence that we have. It's for most eligible patients, this should be the preferred one. And it's particularly important for those who may require other surgical considerations. For example, they may have associated mitral valve disease, thickened leaflets, papillary muscles may be abnormal, the bifid muscles that were talked about earlier, and or associated coronary disease. It's time-honored. It's about 60 years old. Dr. Tajik, delved into that a little bit earlier when he was showing his eagle eyes. And is one of the oldest open heart procedures that continues to be used. It provides a durable gradient relief and eliminates the systolic anterior motion of the mitral valve, which also causes mitral regurgitation, is associated with that. So it has evolved, again, that was mentioned earlier by Dr. Tajik, from the classic Morrow procedure, with the removal of the muscle from just the proximal anterior septum to the widely adopted extended resection. It has very low mortality rate, about 0.6% now, with long-term survival that's comparable to the general population, but again, performed in experienced multidisciplinary institutions, hypertrophic centers of excellence. Perioperative mortality for myectomy is pointed out now about 0.6% and one of the safest currently performed open heart procedures. So the guidelines stress this importance as well. So what is alcohol septal ablation, on the other hand? Well, this procedure developed because it was well documented that surgical resection of the basal septum affords symptom relief and gradient reduction. It's generally recommended for patients who are not surgical candidates, again, due to comorbidities, advanced age, but they need to have a suitable anatomy to subserve this procedure. It's a less invasive alternative to myectomy. Again, low procedural mortality, but may be limited by anatomical considerations of the coronaries. It affords a transmural infarct, which is caused on the table. And because of the potential of creating a ventricular septal defect, it's generally not performed if the septal thickness of the target area is less than 15 millimeters. And is generally performed through a catheter introduced into the coronaries, and then placing a balloon, and then instilling alcohol very carefully and slowly through the catheter, and then causing the localized infarction, or patients generally may say a heart attack on the table. It's a very controlled setting. So in conceptual terms, it's very straightforward. In reality, a little bit more complex. There's no randomized trial data that compares septal ablation to surgical myectomy. And there's also some concern that, some of the interventionists may not adhere to all the indications. So again, important is a hypertrophic center of excellence, multidisciplinary institution, and where there is a thorough discussion before any of these procedures is undertaken. In general, you need to have a minimal septal thickness of about 18 millimeters or more. There should be no coexistent valve disease, which could then be easily addressed by surgery. No abnormality of the subvalvular apparatus that again could be treated surgically, so it's coexistent disease. You don't want to do septal ablation in those patients. And again, there's severe coexistent coronary disease, again pointed out earlier by Dr. Galazga, where she pointed out that patients with HCM are not immune to coronary disease. And you need to have an appropriate perforator that supplies the target area of interest. So experienced operators, dedicated HCM program, and then obviously a balanced and a thorough discussion, because it does afford an alternative and an attractive one for patients. If you tell them that they're not going to have a sternotomy, and they're not going to have an open heart surgery, so they will think about this procedure. But it has to be a balanced discussion or thorough discussion, and patient expresses a preference for septal ablation. Then and then only would you do this. So part of the shared decision making that we talk about in modern cardiology. This graph just gently mentions the major differences between myectomy and ablation. Important is that the pacemaker rate is higher in ablation, 5 to 10% versus about 1 to 2% in myectomy. There is a talk, and there's always been a general consideration that does septal ablation put patients at higher risk of sudden death because of the scar formation that it causes with a controlled heart attack. It's uncertain. It's not exactly 100% clear if that is true, but there's also the discussion has been held, and Dr. Tajik has his opinion about it. He does believe that scar is caused by the infarct, and we've seen that. I have a patient where we repeatedly after the infarct or ablation, we repeated MRIs, and there's been some increase. Again, available follow-up is not as long as it has been for myectomy, as ablation lesser, because it was first performed in 1994. Myectomy dates back to 60 years, and scar is the same as sudden death. Scar is present after ablation; it's not present after myectomy. Great introduction, slightly higher with surgery, a little less than with alcohol septal ablation, but otherwise symptom decrease. Both subjective and objective are decreased, and mortality is the same. It's a safe procedure done in, again, in a center of excellence and with experienced operators. So in general, septal reduction therapy is not recommended for asymptomatic patients with normal exercise capacity and those whose symptoms are well managed with medical therapy. They shouldn't really be considered for septal reduction therapy. Myectomy is generally preferred because of the higher efficacy and better long-term outcomes, so to say. Septal ablation is a viable alternative, particularly for patients at high surgical risk. But both procedures have to be performed at experienced centers, which I pointed out earlier. The guidelines emphasize the importance of shared decision-making, and this approach ensures patients are fully informed about the risks and the benefits of the treatment options. And these recommendations underscore the importance of individualized patient assessment and the expertise of the comprehensive HCM centers in optimizing outcomes for septal reduction therapy. We have seen essentially a dramatic drop in septal reduction therapy at our center since the introduction of mavacamten. In fact, we're planning to report that data at the AHA. We've had almost zero septal reductions in the last, maybe 18 months. Since the introduction of mavacamten. So not great times for people who do these procedures, but great times for medications and for HCM in general. And part of the problem is also going to be, when you lose the expertise of these procedures, where you're going to find if you haven't done a procedure in a long time. And that's true both for surgical myectomy as well as alcohol ablation. That'll be it from me. Thank you.
Thank you, Fawad. That's well said, nicely summarized. The two septal reduction therapies that are currently available. And you also gave a little glimpse into the fact that with the myosin inhibitors, the scene is changing for patients, and they may not need these invasive procedures as frequently as we've been doing. Now, we'll see with further experience with myosin inhibitors whether the failure rate is 10%, 15%, 20% in complete relief of obstruction. And only time will tell that as we follow these patients longer and so forth. So now we move on to the next topic. Thank you, Fuad, which is the end stage HCM, what is available for the non-obstructive types that we asked Dr. Asad Ghafoor, that I introduced earlier on, as the expert in advanced heart failure therapies, HCM, and in cardiac amyloidosis.
Thank you very much, Dr. Tajik. It's great to see Dr. Galaska, Dr. John, and all the attendees, Dr. Peters. I've had the honor of presenting this in the past, and just so you know, Dr. Tajik told me that I should have the shortest presentation because I'm the big bad wolf that is going to scare all the patients. So I'm going to keep my comments about transplant and what is to offer very brief. But you know, what you should remember is that a minority of patients end up needing our help in terms of advanced therapies like transplant. I have no pertinent disclosures for today's talk. And, you know, I always have said, and this is true in HCM as it is in other cardiomyopathies, you know, you can try all the medications and the septal reduction therapies. At some point, for some patients, they need, you know, a complete replacement, heart replacement therapy. And as some of you may recognize, this is President Truman, and he was famous for, you know, saying this particular phrase a lot, the buck stops here. We generally feel that way in the heart failure transplant world about advanced cases. We try to reverse the course of progression in these end stage cases and give them a new life. A lot of our patients, the day they get transplanted, they remember that day as their second birthday. And it's a new life, a new beginning. So, you know, we've had a very privileged history in heart transplant at Aurora St. Luke's. Our first transplant was in January of 1968. And, you know, this person made it to the news because at the time, this transplant was the longest living. This person passed away in 1977, 9 years later. And this is New York Times from 1977, basically saying that in a rare event, a heart transplant patient lived up to 9 years. We, you know, speculate in retrospect that without immunosuppression, this was possible only because this was, you know, just a very lucky match, a very good HLA match that did not require much in terms of immunosuppression. At the time, in the late 60s and 70s, without immunosuppression, most patients were passing away within weeks and months. It was rare to see somebody live past 1 year. And, you know, at the time, Life magazine had this very sad prologue about heart transplant, and they looked at the history of transplant as a tragedy. It was in the 80s with the advent of immunosuppression that things got much better, and by the late 80s, the 1 year survival was above 90% nationally. So, you know, we have a long history of commitment to transplant at Aurora St. Luke's. We were the first ones to do it in Wisconsin and do it successfully. This is, of course, that patient, you know, after recovery, and they're showing a picture of her in 1971 at a bowling alley in West Allis. So, you know, we've done more than 1,000 heart transplants. We reached that milestone during COVID. We generally average around 25 to 30 heart transplants every year. 2020 was an outlier year, and it was predominantly because there were more organs available to us to transplant because a lot of the bigger transplant centers in Chicago particularly had closed down during the pandemic. But I mean, at least what we've estimated is at least a 3 to 5% of our transplant recipients are hypertrophic cardiomyopathy patients. And, of course, these referrals, the majority of them, vast majority of these referrals come from Dr. Tajik's clinic. And of course, he has built the hypertrophic cardiomyopathy clinic to be a very successful one in Wisconsin. And of course, Dr. Galaska will continue that tradition. Some things to know about, when do people get referred to us? It's, of course, if they continue to have symptoms despite the best medical therapy. This includes septal reduction or medications for obstructive gradients like mavacamten. Of course, malignant ventricular arrhythmias sometimes take an unpredictable and overpowering course in hypertrophic cardiomyopathy. That alone can become an indication to list somebody for heart transplant. What we've noticed that even though the general criteria for our patients to get listed in terms of peak oxygen consumption is usually less than 14 and less than 12 for patients with beta blockers, that rule does not strictly apply to patients with hypertrophic cardiomyopathy. And it's simply because a lot of them are younger, and a lot of them may have more arrhythmias than true heart failure as their predominant feature, which forces us to look at evaluating them for heart transplant. Again, as many others have probably pointed out, ejection fraction is not a good way to look at advancing disease in hypertrophic cardiomyopathy. A lot of our patients would be considered to have mildly reduced ejection fraction with hypertrophic cardiomyopathy, but they truly have end-stage disease. The most important thing for everybody here to know is that the outcomes for these patients while they're waiting for transplant are very similar to other patients. They're not in any other way disadvantaged. In fact, there's data to say that post-transplant, their outcomes are actually slightly better than other etiologies. And I'll show you a slide to that effect. Let me just, this is from the 2020 guidelines for hypertrophic cardiomyopathy, where they basically are indicating that there's a lot of different ways your patient could end up getting evaluated for heart transplant. Of course, they give heart transplant a class 1 indication in end-stage disease. Left ventricular assist devices are not commonly used for this substrate of patients, and the guidelines do give it a 2A in select cases. But as I pointed out in the earlier slide, it's predominantly arrhythmias or advancing symptoms despite medical therapy. Those are the patients that get referred to us. So we get this question a lot about what are the criteria like for people with hypertrophic cardiomyopathy. Before the 2018 iteration of the heart transplant listing criteria, hypertrophic cardiomyopathy patients were very disadvantaged. They had no protection in the listing for heart transplant. But in 2018, as the new listing criteria came out, they gave a protected status to hypertrophic cardiomyopathy patients. They could at any time be listed as status 4. They didn't need, a device or inotropes or any other medication or mechanical support device to list them, on the transplant list. So this was new compared to the older version of the listing criteria, where patients with hypertrophic cardiomyopathy were disadvantaged because the only way to be listed higher was to have, a mechanical support device or high-dose inotropic therapy. I should say that you could be listed as high as status 2 without a mechanical support device with hypertrophic cardiomyopathy. There are some specific rules that are, basically set forth by the OPTN, which is Organ Procurement Network Committee. And, for NYHA class 4 symptoms, who we can prove that they have end-stage disease, they can be listed status 4 with a SWAN without a balloon pump or without inotropic therapy. That's something we recognize, but if you don't have some of those features, you could easily be listed status 4. Now, most people who get transplanted in this day and age, they are listed status 2, as you can see here. And status 2 are the people who have a mechanical support device. They have either a balloon pump or an Impella. But as I just pointed out, hypertrophic cardiomyopathy patients with certain end-stage features can be listed status 2 without a balloon pump, Impella, without inotropes, but you have to meet certain criteria. So status 1 are the sickest people who require both heart and lung support with a VA ECMO machine, and generally that is not the best way to get your patient to transplant, but status 2 is most commonly the way we try to get our hypertrophic cardiomyopathy patients to transplants. This is the most recent version of post-transplant outcomes highlighting hypertrophic cardiomyopathy as a specific subset. And in green, you can see here how their survival is better. And in this schematic, you can see up to 5 years out, their survival is better than everybody else. This is generally true, we believe, because these patients are younger. They have otherwise good organs, liver, kidneys, and so their end organ function in many ways is preserved. The only thing they need is a new heart. So this will be true, in the future. It's probably always been true in the past. And the younger your patient, usually even without hypertrophic cardiomyopathy, the better the outcome. I'm just going to put in a little bit here about mechanical assist devices like left ventricular assist devices. These are an option for a very small minority of end-stage hypertrophic cardiomyopathy patients. We have had a few patients need this, particularly if they were a common blood type and we could not get them an organ available very quickly and their life was at danger. We would, in those circumstances, put a mechanical pump and then list them with a mechanical pump for heart transplant. And if anybody's interested, we do have patients, hypertrophic cardiomyopathy patients, that had a pump like this, and we could definitely, we call them patient ambassadors or mechanical support device ambassadors. We could definitely connect them with you if you had questions for them, or if you felt that you would like to know more about life with the LVAD in a hypertrophic cardiomyopathy patient. Of course, this is just to let you know that there are patients who may not be on the transplant list and get a mechanical pump. In these situations, we call it destination therapy, or sometimes we call it a bridge to decision. Bridge to decision meaning that they may be eligible to be listed for transplant later, but at the time that they were getting a mechanical pump, it was uncertain that they were candidates. But again, this is only an option for a very small minority of hypertrophic cardiomyopathy patients. So with that, I will stop here. And of course, if you have any questions, I would be happy to answer them for you. And thank you for having me.
Thank you, Asad. That was nice update there. And now to our last presenters, last but not the least ones, and they're our nursing staff. Where are they? Amanda and Heather. Showtime. What's the key role for
They're
nurses
hiding.
and nurse practitioners?
I'm happy to jump on if I need to go out of order of the agenda.
Hello. Okay.
I see Amanda come back. I'm going to guess those nurses were multitasking.
Okay.
Never,
That.
never do a multitask.
So, Asad, I don't know whether you. Oh, are you ready, Heather?
I am. Oh, Amanda's now here. So
There she is. Amanda's here.
Yes, I'm here. Heather, did you want to start your slides first, or did you want me to go?
does not matter to me, whichever. And since I think you were listed as going first, we can stick with the original
Okay.
agenda.
Sure, perfect. All right, one moment. I am used to having two screens, so now that I do not have my two screens, I am just fumbling through this, but we are going to make it work. Let's see here.
So as you're preparing, I'm just making a comment that as Asad Ghafoor was talking about transplant and all the ramifications, I could see Lisa with her hands up like this and thumbs up and all that she was doing.
So I have a trivia question for you. Who wrote the guidelines for
Who-
transplant and HCM?
Was it somebody from Mayo?
No, it was somebody in this room right now. And they don't have an MD after their name. Care to take any guesses? So it's an interesting story. I'll give you the abridged version. After my transplant, I was actually reviewing the documents for the new listing criteria when I was hospitalized and needed a transplant, and I didn't know it was coming that quick. So I didn't think it was ethical to give a review of the document at that time. But after my transplant was completed, it was almost like 6 months after my transplant, I contacted UNOS. I'm like, this isn't working. How can I help? And they asked the HCMA to draft some guidelines. So Marty Marin and I did the draft, submitted it to UNOS. It went through the process, and there was no changes to our original draft. So what you see is what Marty and I wrote, and that's the guideline criteria today that is utilized.
Fantastic,
So a
Lisa.
patient wrote the guidelines. How do you like that one?
Great.
So
Okay, Amanda, are you ready?
Yes, I'm ready. As
Okay,
long as you can all see my screen.
go ahead. Thank you.
Very good. So my name is Amanda Masika. I am the nurse cardiac care coordinator here at the Hypertrophic Cardiomyopathy Clinic at St. Luke's in Milwaukee, Wisconsin. I'm very fortunate to work with my colleagues, Heather Sanders. Every day we sit right next to each other, Dr. Tajik, as well as Dr. Galaska, Dr. Peters, Dr. Ghafoor, Dr. John, and a slew of others that are behind the scenes every day that really make what we do possible. So I would like to go over what happens in every single case of a hypertrophic cardiomyopathy patient, because it is perfect for everybody, as you all know, right? There is a trigger that tells a physician, let's say outside of the specialty office, that a patient may need to have an echocardiogram because they have been tired for some time. There's a red flag on said echo, and they must go to the cardiac specialty center. They come here for a full workup, and we are ultimately able to diagnose them with hypertrophic cardiomyopathy. We offer treatments that include possible myosin inhibitors, but starting with beta blockers or calcium channel blockers, and then patient is then feeling all better. And that happens at every time, and we're all very excited about that. And I hope that you all know that that is not true. That's sometimes not what happens at the very beginning when patients are seen, let's say just even by an expert. The expert's opinion could be your TTE suggests HCM with possible dynamic LVOT obstruction. We'll get a CMR to assess the myocardial thickness and LGE with a CPET to quantify functional impairment, and we'll start you on a beta blocker. Depending on your NYHA class, we may consider initiating mavacamten via REMS, and you'll follow up with our team, likely multimodality with EP and imaging. Of course, to the patient, that's very scary. Not to say that any of our physicians or APPs would ever use that type of jargon with patients. I think that we do a very good job at meeting patients where they are as far as understanding their diagnosis. But I think what we do a very good job of is identifying that there are going to be a lot of questions from patients about what is obstruction, and obstruction could happen in many different areas of the heart. What is a CMR? What is a CPET? MAVA what? You know, REMS, what is REMS? And having to say risk evaluation and mitigation strategy umpteen times a day, it's a mouthful. But taking the time with our patients to really work through all of the different nuances of this disease is something that I am very proud of. And at the heart of what I do, and the reason for what I do as a nurse within this clinic, is because I get to watch patients go from being scared to empowered. I can't tell you how many positive stories that I could share on patient advocacy moments with insurance, or starting on mavacamten and finding just a new lease on life, translating clinical speak into something real, reassuring, and tangible for patients. We have patients coming in at age 22 all the way up to 93, and all with different backgrounds with educational offerings. So we do a really great job of meeting any of our patients where they're at, as far as understanding their diagnoses and possible treatments. I really enjoy being the person that patients call when they don't know what to ask. I can't tell you how fortunate I am to collaborate with such brilliant minds, and they allow me the opportunity to make that brilliance understandable to patients. And all of my colleagues have been very patient with patient care, which I find just so encouraging. We're able to spend 30 minutes to 60 minutes and sometimes 2 hours, depending on the patient, just because they need it. Not allowing cost be a prohibitive factor in taking Camzyos, or mavacamten as we often refer to it. That is one of the biggest wins that I could say for our office, is that that's never been a factor for us. Watching a system that I helped design give someone their life back, kind of speaking more towards that Camzyos and mavacamten realm, being able to hear that people can now take walks after dinner, or feel the ocean breeze as they're going on a tropical vacation for the first time in years with their family. That's something that is just life-changing for me to be a part of. Making patient access tools from industry work within our system and not around it for smoother and faster treatment starts. I am very proud to be able to work with all of the pharma representatives that come to our office, and collaborate with them on where we can kind of integrate our tools along with their tools to make sure that our patients are getting the best possible care. What I hope resonates most from my very short presentation is that hypertrophic cardiomyopathy is definitely complex. You don't have to navigate it alone. We take a lot of pride in being very deliberate with our care delivery, enlisting all of the experts within cardiology care here in Milwaukee. We are very proud to be Wisconsin's only center of excellence. We wear that badge with pride. Please ask questions. Any patients listening still here now, please ask any question that comes to mind. No question is ever too silly or too rudimentary, because any question that you ask, I can almost guarantee you that somebody else is thinking of that. And if you ask me that question, I'm going to figure out the answer, because I love rabbit holes, and I'm going to make sure that we all find the answer, because I want to be able to give that answer to the next person that asks. The right care excuse me, the right care takes teamwork, and you're at the center of that teamwork. You are the entire reason that we're here. Without patients, we would not be around. If there was no disease, which it's unfortunate that the disease is here, but we would not be able to care for all of you individuals and prospective individuals. You have a nurse here, me, Amanda Masika, who is obsessed. I have probably some obsessive compulsive issues. There's a lot of other things that I should probably not delve down such a rabbit hole with, but I'm obsessed with getting it right. I'm obsessed with making sure that the answers are going to be, or the questions are going to be answered. And I need to know why. You know, if there's ever a problem, I will always ask the why, even in what seems to be a difficult or kind of sketchy situation, or it makes people nervous. I don't mind. I will always ask the question. So please ask questions to me so that I could be your advocate.
Good job. Good job. Heather, that's Thank you, Amanda. That was well done. Very well.
Thank you.
Let's hear Heather, and then we'll open up for questions.
Yes.
Very questions you're looking for. Okay.
And let's make sure I can do this the right way. Be on the right screen, hopefully. You good to go?
Yes.
Okay.
You're on the right
So,
screen.
to follow up with Amanda, who is an integral part of our nursing team and entire treatment team. We call her the expensive drug queen because she is awesome at her job of making sure patients don't pay for their expensive new medications, whether that's Jardiance or Vindamax or Attruby or any other drugs that are used to treat the mimickers of hypertrophy, as well as the Camzyos that treats hypertrophic cardiomyopathy. Nurse practitioners are kind of like the bridge between RNs and physicians. We give a little bit more opportunities to spend more time with patients. We triage complex diagnostics and patient charts to determine, are they a hypertrophic cardiomyopathy patient referral, or are they a phenocopy of hypertrophic cardiomyopathy or belong somewhere else? We get to differentiate between whether something is benign or urgent when it comes to symptoms, that chest pain that, it has been bothering them for 4 months and now prompted a phone call. What made it different today? Why should we see you more urgently? We fix schedules with patients who have issues with trying to get transportation, or have scheduling issues with their jobs, because, as Amanda alluded to, our age range is anywhere from 22 to 92. So we have retirees who have transportation limitations, and we have younger individuals who have to work in order to have their healthcare insurance so they can be seen at centers of excellence. So it's trying to figure out who we can move and how we can get patients in a timely manner. We follow evidence-based algorithms that have been mentioned by my physician colleagues this evening as to how to treat them appropriately, but also be able to adapt them to more real-world situations, and making sure that those treatment options come in a timely manner. As Amanda also alluded to, we are here to help make sure that they understand their condition, that we can identify literacy gaps and make sure that it's understandable for everybody at any age. Speaking in plain languages, interpreting what some physicians have told them, making sure that everything is written down in language that they can understand. So when they go home and their loved one goes, well, what did the doctor say? They don't have a blank look on their face. They have somebody that can, has written it down for them. We are also here to advocate for those who have been dismissed. We had a patient who kept being told she was just dehydrated and not feeling well. She ended up in cardiogenic shock, finally got transferred to our center, and we essentially saved her life and diagnosed her with obstructive hypertrophic cardiomyopathy. And as a result, she was able to walk her granddaughter down the aisle at her granddaughter's wedding 3 months later. We use shared decision-making to involve patients in these difficult choices. Hypertrophic cardiomyopathy is a familial condition. It affects not just the patient, but their loved ones. It's inherited. It can affect all of their loved ones or none of their loved ones. And sometimes those difficult choices are hard to make, and we are here to lend that ear. We spend extra time with patients who are anxious. I had a patient the other day who he's had the disease and the diagnosis for years, but is now, is anxious again. What if my device goes off? How can I go? Am I allowed to do this much activity? Or how can I be somebody that is a 25-year-old individual and live life the way I would like to live life? Amanda alluded to spending 2 hours with the patient. I had another patient who essentially was just at her wit's end, and needed to be able to vent and cry to somebody who was an unbiased ear, and walked out of here feeling heard and feeling better. And that was an exceptional opportunity to have. At one point, I was also the genetic counselor, but fortunately we now have our own dedicated genetic counselor. So that takes a little burden off of our shoulders. But as nurses, nurse practitioners also do a little bit of everything to make sure that patients are seen, are heard, get the care that they need, and support their families. And as Dr. Tajik so eloquently said at the beginning of this presentation, having been in this clinic with him for the last 10, 12 years, we have seen the transition of care from basic beta blockers to surgical interventions to now the era of myosin inhibitors. And the stories we hear from patients who are able to use them and how much their lives have improved has been very rewarding. And we're anxious to see what the next decade holds for hypertrophic cardiomyopathy and how to improve patient lives. That's all I got.
Okay, Heather, thank you. And Lisa, we have some time.
Thank you so
oh.
much. I'm sitting here listening to some of the things that you say, Heather, and boy, we're living parallel lives in so many ways, but you get that clinical responsibility. Thank you so much for taking that. Just the ability to have somebody on your team that can take the time to hear somebody out after they have been maybe dealing with a long odyssey, there's that word again, of HCM care or mismanagement, or maybe just trying to keep it in so long that it was bothering them. The young man that you had who didn't feel any symptoms and then all of a sudden was frustrated and anxious. If you go a long period of time being asymptomatic, when those symptoms start popping up again, it's terrible for some of these patients. It's worse than the original diagnosis in some cases, which is why HCMA is endeavoring to build something new. This is early data, early information, but we are trying to build a mental health network so that we have therapists who are trained in understanding the unique challenges of those with genetic, longstanding chronic heart disease. And God willing, we can get this funded and we can get the wheels on this by probably, we're hoping for early next year that it can start to be functioning. But we're going to create a CME course with mental health professionals to train other mental health professionals so they understand the unique triggers and anxiety we have and how that anxiety can actually really be detrimental to our overall health because it makes your heart rate go up, it makes your blood pressure go up, and none of that is good for HCM. Am I right, Dr. Tajik?
Oh, yes, absolutely. Yes.
So
So,
thank you to everybody here. We do have some questions. Dr. Tajik, did you want to start with some questions for your team?
I, do you have the questions? I don't
Oh,
have.
Your team has been really good at answering the questions in the queue as the meeting has been going along. So I'm going to recap them so everybody can benefit from the knowledge. So I'm going to go into the answered and I'm going to kind of go through some of the ones that I think might be relevant for others to learn from if they're not looking at the queue. Valsartan is the one I normally get asked about the most. Does Valsartan benefit non-obstructive HCM? And the answer, Fuad, if you want to answer the question that you wrote, you answered in writing, or you want me to read it, whichever you choose. You're on mute, so something's got to change.
You're mute.
The button. Hit the button.
Fuad?
Yeah, I'm unmuting myself.
There you go.
I think there are two unanswered questions so far, and I think Dr. Ghafoor should take them. They're related to the
I'm gonna go back in the queue for the purpose of making sure everybody gets the education, not just the asker of the question. Because when we answer them in queue, not everybody can always see the answers because they don't know how to use it or they didn't notice it. So the question about sartans and HCM for medical management of non-obstructed HCM, can somebody just tell the listening audience what the role of sartans are in HCM?
I'll let Dr. Tajik take that question.
Dr. Tajik, what are the role of sartans in HCM?
I thought Ghafoor is going to take the question.
Go ahead.
Yes.
So,
So, okay. Okay, go ahead.
what was the question?
Oh, the question is losartan and HCM.
Yeah.
Valsartan.
Yeah. Well,
Well,
the angiotensin receptor blockers,
Basically all the ARBs.
candesartan was one of them.
you know, there is that trial that done with valsartan in individuals with non-obstructive disease and improvement of diastolic dysfunction has been demonstrated. So these are some aspects that we are designing ourselves against fibrosis. So you can be on aldactone, eplerenone, you can be on a calcium channel blocker, and also on a valsartan or one of those agents as well. And we don't have the proof, but these are just clinical decision-making process to choose one, two, or all three of them in order to provide anti-fibrotic measures. As we all know, that's the major quintessential abnormality of HCM is fibrosis development.
Thank you very much. And there's a question, and I'm going to clarify the answer. Jason asked, are there any treatments or medications coming down the pipe to address higher than usual tissue scarring? And Matthew appropriately answered, we don't have any specific medications right now, and a study on spironolactone and others, but there is a new company creating an antifibrotic. The company is called Haya. It is early days. It is a new type of technology. So pipeline, yes, there's something in the pipeline. How long till we see proof from that pipeline drug? Your guess is as good as mine. So it's going to be a while on that one. They're just starting trials now. So you're talking at least 5 to 7 years before we really see anything that's going to hit the street, so to speak. Is this being recorded? Yes, this is being recorded. Immediately when it's done, you're going to be able to rewatch it on Facebook tonight. If you want to go back and relearn something, it'll be on YouTube tomorrow. It'll be on the HCMA website by next week. SGLT1/2s, I think we've gone over that now. Devon, you are talking about your child suffered a cardiac arrest while in school. You state that he was an athlete. He was diagnosed with HCM, now has an ICD for 2 weeks. What should your next steps be? You should be calling the HCMA office, setting up an intake and navigation call, getting plugged into all of the resources we have to support you and your son through this journey. You should be finding an HCMA recognized center of excellence to be the care partner for your son. And you should take a breath because your son is now protected by an ICD. Dr. Tajik, what would you tell a mother of a 12-year-old who's recently diagnosed?
So genetic testing also very critical in that kid and also in the family and the siblings, So that will be very important. I think this, and what you said was they have to be followed and cared for by HCMA expert center. Yeah. And he's 12 years old, so that's going to be a pediatric center. Yeah.
Definitely going to be a pediatric center. Someone asked, how common is it for a patient to have a myectomy followed by an alcohol septal ablation? Incredibly rare. In my experience, it happens once in I wouldn't even say a blue moon, I'd call it a purple moon, because I've seen somebody try to go in and tighten up after a myectomy with a little alcohol. I don't necessarily think it's the safest approach. Could my team discuss the potential role of pacemaker dependency after such a situation?
So just a quick answer, we don't have big experience with this either, but I've just looked at after septal reduction therapy, we have, I believe, 12 patients that have required mavacamten, Camzyos, for management. They still had severe obstruction. So some of them were surgical, some were alcoseptal ablation that came for Camzyos help, and it was effective in that subgroup. So this is a small group and small experience, but that does exist.
You got people sending a lot of love in the questions too and telling your team how wonderful they are. I'll make sure you get copies of all of those after the event because I'm sure everybody will want those in their personal files, just so you have them. Okay, thank you all so much for what you do. And an interesto question. Okay, I'm going to go to the questions we have not yet answered. Amy, I'm going to leave yours for last because, you know, it's a little bit more complicated. What is the criteria to be listed status 2 with no mechanical device?
So I can take that one.
So thank you.
If you have resting symptoms, meaning New York Heart Association class 4, and you have evidence, and you have a Swan catheter, a continuous cardiac output Swan catheter, and basically we have evidence that you are hemodynamically decompensated, and the specific hemodynamic criteria, you either need 2 hemodynamic criteria or 1 hemodynamic and 1 end organ dysfunction criteria. So the different options for hemodynamic criteria are that you either have a systolic blood pressure less than 90, you have a wedge pressure more than 20, you have a cardiac index less than 2.2, you have a mixed venous oxygen saturation less than 50, you have a transpulmonary gradient more than 15, or a pulmonary vascular resistance number more than 2.5 Wood units. Those are the hemodynamic indicators. You can get all this information with a Swan catheter, or you can have, either have 2 of those, or you can have 1 of those with 1 end organ dysfunction indicator, which would be either a lactate more than 2.5, or a creatinine that is more than 50% above your baseline, or a total bilirubin that is more than 50% above your baseline, or your liver enzymes, the ALT and AST, have doubled compared to your baseline. So either 1 of the hemodynamic instability and 1 end organ perfusion criteria, or 2 hemodynamic instability criteria. In end-stage hypertrophic cardiomyopathy patients, these criteria are frequently present, but you do need a Swan catheter to catch, these numbers and document, and, So now I should say that in these cases, you are oftentimes using as much inotrope as you can, as the patient's, disease will allow. Arrhythmias, whether it's atrial or ventricular arrhythmias. So because that's the only thing you can do, you can't use mechanical support devices. So the guidelines do say that they have NYHA class 4 symptoms and maximally tolerated inotropic therapy, and, one of these criteria.
Okay.
To those who are not in the transplant world, that sounded really intense. Each one of those items that he listed off as being a potential factor. If you are in a high volume transplant center, they're watching all of these numbers regularly as they're evaluating you. Should you have any questions, don't hesitate to give us a call and we can align you with proper resources, but your team is probably giving you that information. So we have a thanks for the great lecture. I have a question about how risk stratification is done to prevent sudden cardiac death in patients with HCM. I will tell you there's lots of long talks that you could hear on this throughout the Bighearted Warrior Tour series and through our through our podcasting as well. So we'll give an answer here. I'm sure we'll have somebody wanting to do that, but then you can take a deeper dive into all of the risk factors at a deeper level in another edition of the Bighearted Warrior Tour. Dr. Tajik, did you want to take this, or did you want to remember, or maybe Patricia?
Patricia Glasgow, they were perfect for this one.
I thought so.
Yeah, happy to. Yes, we so the risk stratification starts with a patient being in clinic and gaining the history from the patient. So the first thing is what we want to know is what is the family history, and is there a family history of sudden cardiac death, which is a very important factor. The other thing is imaging helps us tremendously with further risk stratification. So as we've mentioned, wall thickness, the thicker the wall of the left ventricle or the pumping chamber, the higher the risk of sudden cardiac death. Specifically, that wall thickness more than 3 centimeters is included in the guidelines for sudden cardiac death stratification. The other things which we look for is obviously arrhythmias. So we do Holters regularly, we do them yearly. We look for more frequent arrhythmias, faster arrhythmias coming from the lower chamber, so ventricular arrhythmias specifically. The other thing is if somebody potentially has mid-ventricular to apical HCM, if there's a left ventricular aneurysm, we know that aneurysms specifically put you at a higher risk of having ventricular arrhythmias. So that's another risk factor. And obviously there's the LGE, or the amount of scarring that you have that you can see on the cardiac MRI. And that scarring sometimes may be difficult to sort of delineate on cardiac MRI. Those numbers can vary from time to time. I always tell my patients that there's a potential of being in a gray zone, but again, this is something that we can evaluate with history taking, with imaging that can help us, and with other monitors that can help us sort of have a bigger picture. But obviously it's a shared decision making during the clinic visit. We speak with a patient. I usually personally like to do the HA calculation, the HCM, send that calculation for the patient. What is their risk compared to general population within the 5 years for sudden cardiac death, and then review all of their risk factors and decide when should they be referred to electrophysiologists or the electrician of the heart for further discussions.
Nice.
That's a good short version there, and they appreciate that. So we've answered that one live. Some of us are allergic to contrast material. Can we talk about the gadolinium and the commonality of being allergic to gadolinium versus the older contrast dyes?
So I can take that
Mhm.
answer. So the newer agents that have been tested, what we worry about with gadolinium when we give patients gadolinium, if somebody has, for example, renal dysfunction, we worry about systemic nephrogenic fibroses that can occur within that could be very detrimental to patients' health. But what we've shown with the newer agents that are out there at this point, that risk is minimal. And together, the Society of Radiology and Nephrology have come together and said that these agents can be used in patients even with chronic kidney disease or end-stage renal disease, obviously with discussions with the patient with very minimal risk. So obviously allergy as an anaphylactic reaction, that is something we probably, if somebody had an anaphylactic reaction where they became short of breath, potentially needed intubation, that is something where we will avoid it at all costs. We're not going to do it. But if somebody had allergies such as hives or a low risk allergy, then we can potentially give pre-medications such as steroids, Benadryl to help with that. But the risk of, as I said, NSF is very, very low.
Okay. I have a question, but I'm going to do Amy's first, and then I have a follow-up question to round this all out. So if somebody has been, I'm not going to give all of the statistics here in the question. Somebody has non-obstructed HCM, septal wall 1.9, EF 55, blunting, but showing progressive heart failure symptoms. Lots of congestive heart failure, fluid overload, shortness of breath with activity. She's being worked up for a transplant, and got a comment through her transplant process that we don't transplant somebody with an EF of 55. What is the role of EF in HCM for evaluation of transplant?
So I can take that one. You know, hypertrophic cardiomyopathy, like some other conditions like amyloid, is not the best one to just look at through the lens of ejection fraction alone. And, you know, there are patients with amyloidosis, hypertrophic cardiomyopathy who may have an EF of 50%, but really their heart is much more dysfunctional than that. And we can tell by looking at their hemodynamics and their cardiopulmonary exercise test, information. So I would not say that to a patient that because your ejection fraction is 50 or 55, that your heart is not sick enough to be transplanted.
You know that picture that Patricia showed earlier of a heart with me holding one because it was my heart? My ejection fraction was 52% at the time of my transplant. But I had a cavity that had no space. So 50% of what?
Yeah.
Kind of sad. Okay.
And
Amy, I think we got you there on that answer. So I have a question for Dr. Tajik.
Yes.
Did you ever think you would be sitting in your home or your office and see television commercials for hypertrophic cardiomyopathy?
No, I should have brought that in my journey and add that television aspects. But yeah, I mean, this is fantastic. As I reflect on this whole thing, process from the 70 until now, as the journey continues, unbelievable milestones have happened. And they are milestones for cardiology as well, total, not just for HCM. Number of these milestones that were achieved affect the entire cardiology as well. It's a fascinating journey. Has happened to date is for the betterment of patient care that has happened. Fantastic. The risk of sudden death has been reduced, not totally eliminated, but it's gone down very low. Overall mortality of this condition has been markedly reduced from what used to be close to 5 to 6% annual mortality in the good old days. I shouldn't say good days,
Bad old days.
bad old days, and now down to less than 1%, maybe 0.5% yearly mortality for this group of patients. It's fantastic achievements. So exciting. I'm really, every day when I'm in the clinic, I'm excited. And that we are able to help the new patients that we see in a very excellent manner.
We have a comment from somebody who wants to do yoga by the seashore, just like Stephanie in that TV commercial for Camzyos.
Huh.
And I'm going to guess that one of our representatives from BMS is still listening. So
Okay.
I don't know. I can see BMS funding a beach trip for everybody on Camzyos. Only kidding, not committing them to anything. But I think the commercial does kind of indicate that that's possible. So I love the commercials. I love the positivity. I think we're going to see more when new drugs come out into the market. So we're going to see HCM in more places. But Dr. Tajik, what you have given to this field is actually amazing. And I don't think most of our viewers really understand the role that you played in early imaging and helping really define what the anatomy of hypertrophic cardiomyopathy is and giving us all that fantastic foundation for us to build upon. So thank you for your life's work and your commitment specifically to HCM, globally to cardiology, but they can get a lot of you. It's what you do for our community. You've got names like yours and Marin and Brunwald, all in the history books that led us to such a solid foundation that we're now really optimizing in the age of myosin inhibitors and beyond, even going into gene therapies. So thank you for what you've contributed to the science. Thank you for bringing this amazing team together for the people of your region and providing them with excellent care. And thank you to all of you for taking time out of your very busy schedules to spend to educate patients on a night in May when we're all getting ready for a nice long weekend, which I was a week off on. I thought Memorial Day was a week and a half away. So I'm really excited that tomorrow's Friday because
Yes.
a long weekend.
Well, thank you and your team. And what you have done for HCM is unbelievably fantastic. Lisa, you have personally contributed from your own family history. And with the gusto that you had, I remember old days of our meetings and things of that nature, and where you have brought this is phenomenal. And we're very grateful to you for your leadership. And I want to thank the whole team that represented Aurora St. Luke HCM Center of Excellence from HICMA, and for their really nice presentations, and to everyone in the audience that have been there and always there. Thank you.
Thank you very much. Real quick response to one other question. Marlene said it's hard to follow all the abbreviations. They're on our website. You can go get all the abbreviations right there. It's also in my book. So you shouldn't be lost. We also have a cheat sheet in our Facebook group. We know the acronyms get a little much. So there's lots of cheat sheets hiding for you. We know that that's a little hard to follow sometimes. So please go find those. And if in doubt, call up the HCMA and say, what does this mean? And pretty much anybody who answers the phone can answer the acronym questions for you. So we're always here to support you and your families. And one part of our work at the HCMA, as we build HCM centers of excellence like yours, it's supporting your team and making sure that they have the resources that they need and the appreciation they need from the patient community. So truly, thank you all for what you've chosen to do every day. we didn't really have a choice. We had to be here because our body said so. You could pick a career path. You could pick a disease state. We're grateful that you picked ours. So thank you very much. Thank you everybody for joining. Thank you, Julie and Stacy, for doing the back end work for tonight and always. And if you want to join us in person again, October in New Jersey, please mark your calendars now. We'd love to have you all join us. We have a great agenda coming up for you. If you're in the Pacific Northwest, don't forget to join us in Seattle in July. And I think I figured out where Asia was from. I think we had China on board for part of the night with us because we have interest from them to build more programs as well. So we're going global. It's going to be out
Yes.
there.
Thank you.
Thank you, everybody. Have a wonderful evening.
Thank you so much.
Bye-bye.
You know,
Thank you.
Thank you.